A hearty good evening and welcome to all. It is said that we should not just add years to life, but life to years. As life expectancy increases, an important question emerges. Are we living longer with good health or simply living longer? Today's academic discussion addresses this very concern. As clinicians, we play a very important role in translating the concept of compression morbidity into practice by prioritizing prevention and promoting health behaviors. So on this note, we would start with our first lecture by Dr. B. Shivshankar sir. His lecture is on denosumab in postmenopausal osteoporosis. Sir is a consultant orthopedic surgeon and past president of Indian Orthopedic Association. He is known for his innovative techniques and instruments, particularly in fracture management. Over to you, sir.
लाईट हॅलो लाईट थोडं कमी करता येते मागचे स्पेशली हे चार कमी केले तर बस इथे राहू दे ते झोपायला सोडत नाही ते लाईट येस इट्स ओके नो नाव येस ओके at the outset I would like to thank Solapur Obstetrics and Gynecology Society for this invitation, and for the first time I am talking to gynecologists and also non-orthopedic surgeons, because my talk is almost always for orthopedic surgeons, and this is the first time I am making this attempt to speak. My first disclaimer, Nilesh Aikun Bagunge, not received any financial support for this talk from anyone, but willing to accept if it is substantial. Few slides, less than 25%, 19 out of 82 in my presentation are sourced from the sponsor of today's event. Few illustrative cases are sourced from my ortho-onco friends. I have clubbed slides from my 3 earlier presentations which I did in 2012 and 17 for orthopedic surgeons and 2022 for Association Physicians of India. That was an online talk. So there may be some repetition of slides, but that is in the interest that stress the point. If you want, I will also talk against this pharma-driven disease at the end, which is not part of this 82 slides. There are additional 20 slides. So, because I am an orthopedic surgeon, I am not married to these torrent people to promote their product. Coming to the definition, it is an abnormal reduction in bone tissue mass per unit volume of anatomical bone. The density of bone becomes less and less. Quantity of the bone is diminished, whereas the quality of the bone is practically same. So if you think this is the quality of a bone, in an osteoporotic bone is also the quality will remain same, but the quantity will become less and less, and that's what we see under microscope like this. So it's just diminution of the normal bone. If you do any biochemical analysis in them, it's practically everything will be normal unless it is totally too much deranged. Coming to the definition, WHO defines osteoporosis as a bone mass density, that is BMD, 2.5 or more standard deviation from the mean. That we will see little later. Coming to the incidence, 1 out of 8 males in India and 1 out of 3 females in India suffer from osteoporosis. About 300 million people in India suffer from osteoporosis. That is 1/5 of the population. If you consider as 150 crores, 30 crore are having osteoporosis. 1 in 3 women and 1 in 12 men over the age of 50 worldwide have osteoporosis. 50% increase in the number of people in the next 10 years. So the osteoporosis will be doubled in the next 10 years. One should understand few things. One of them is peak bone mass in adult. So we all know that in a child the bone will be growing and only deposition will be happening, and by the age of 30-35 it attains the peak bone mass, and it remains plateau for about 10 years and gradually it starts decreasing. So in childhood and adulthood it keep on increasing, and as the age advances it keeps on decreasing. Osteoporosis is the imbalance between bone resorption and bone formation. If the bone formation is more, it's the bone will get deposited. If the resorption is more, bone will start coming down. That's what happens especially in the postmenopausal women. In normal bone, there is a constant matrix remodeling of bone up to, yes, welcome Prasanna. Up to 10% of bone mass may be undergoing remodeling at any point of the time. The three main mechanisms by which osteoporosis develops are inadequate peak bone mass, means तुमच्या बँकमध्ये अकाउंटमध्ये पैसे कमी आहे, you have deposited less amount of bone in your bank. Excessive bone resorption, you are withdrawing too much of money from your bank, so your balance is becoming less and less. Inadequate formation of new bone, means the interest given by the bank is so poor that it is not compensating for whatever the expenditure is happening. So these are the three main things which cause the osteoporosis in all the people. Coming to the classification, we will only restrict to primary, but just for the sake of mentioning, I will mention the secondary also. The primary is postmenopausal osteoporosis and second one is senile osteoporosis. Secondary is due to endocrine causes, gastrointestinal causes, or it can be due to neoplasm, alcohol, smoking, all those things. Alcohol is also too much of alcohol consumption. 23 units per week for a man and 14 units for a lady is still doesn't cause osteoporosis if they are consuming alcohol. The units means 30 ml. That international standard is 30 ml. So everyone can take 90 ml per day without any problem. Or if you are taking once or twice a week, then no problem. 2-3 packs is fine. Anyway, coming to the pathogenesis again, the two most important risk factors are low peak bone mass at the skeletal maturity and accelerated postmenopausal bone loss. We all know that in the postmenopausal period, women will have estrogen deficiency, and estrogen has a dual action. It stimulates osteoblasts to create more bone and it also inhibits osteoclast. So it increases bone mass and also prevents resorption on working on osteoclast. Estrogen deficiency causes bone loss by activation of new remodeling sites, exaggeration of imbalance between bone formation and bone resorption. The net effect of estrogen deficiency is increased osteoclastic activity, and that will lead to osteoporosis. Longevity of osteoclast is increased while osteoblast is decreased in absence of estrogen. That's also one of the reasons why osteoclasts are overworking than the osteoblast and the bone starts getting resorbed. As remodeling is initiated at the surface of the bone, trabecular bone is predominantly affected by estrogen deficiency. As trabecular bone is considerably larger surface area, that is 80% of the total, fracture usually happen in those trabecular bone like vertebra or hip bone. Vertebral fractures are the most commonest fracture which we can see in the deficiency of estrogen in these patients. This is an X-ray which shows all there is fish mouthing appearance of the intervertebral disc space, and there is compression. You can see the height of the vertebra. Even if you consider this as normal, the height of these two vertebrae are less. So this is mainly due to postmenopausal osteoporosis. The second type is senile osteoporosis, which happen both in men and women and usually happens in men over the age of 60. Genetic factors, whites and Asians have got tendency to have more osteoporosis when compared to blacks or African people. How to diagnose? By investigating. It's already too late if you can diagnose it on X-ray. Means X-ray will show osteoporosis only after 40% of the bone is resolved. Till that time it is difficult to say it is osteoporosis. The most important thing, the gold standard is DEXA scan, which costs about 45 lakh rupees. We had one in Sholapur. Unfortunately, that machine stopped working and we don't have at present any DEXA machines available in Sholapur at present. It's highly accurate X-ray technique for measuring the bone density. Any site can be used for measuring the bone density using this DEXA machine. But usually we depend upon lumbar, spine and hip. Usually we measure in L3 lumbar vertebra and also in the hip joint to get the DEXA report in these patients. Portable DEXA machines are available. What we see, the heel ultrasonography, it's ultrasound based, it's not a DEXA based. So it's a poor substitute, but it is a cheaper version. The machine is available between 3 to 6 lakh rupees. So all these companies use them, but that is not a good way of diagnosing BMD. The DEXA measures of the hip like femoral neck, trochanteric area, intertrochanteric area, Ward's triangle and the total hip. And if you see the report, based on the DEXA and the bone mineral density, the osteoporosis is classified into varieties. If the deviation is 2.5 minus 2.5 below the normal one, then it is called as osteoporosis, minus 2.5 below. Between minus 1 and minus 2.5 is called as osteopenia, and above minus 1 is supposed to be called as a normal bone. This is the classification which we should be knowing. This is called as T-score. T-score is nothing but trabecular score. It measures the bone mineral density in the trabecula of the vertebra as well as the hip joint. This definition was given by the National Osteoporosis Foundation of America in 2009. If you read the report shows that this is normal, this is little less, yellow is moderately less, and red below 2.5 is osteoporosis. This is moderately osteoporosis and this is normal. But if you read this, they have given a report saying that it is moderately less, osteopenia. If you read this and take this picture as your guidance, you are totally wrongly treating the patient. The reason is, this is average of all the area. Trochanter, intertrochanteric area, Ward's triangle, head of the femur, everything. Average is given as that. If you consider each point separately, you see that the Ward's triangle is minus 3.5 already. This is the central area. You can see already there is blackish osteoporosis. For that part of the bone, it's already severely osteoporotic. It is going to break. Just because the other part is strong, that is not going to protect this point. So when you see the report, never look at this. Always look at the second or third page where they have given different places where what is osteoporosis. Wherever it is least, you consider that as your standard for that patient. So don't look at this report anytime, and it always shows, almost always shows osteopenia in almost everybody. You have to go specifically and see each area. In 2020, American Association of Clinical Endocrinologists added 2 more entities to this osteoporosis. What they did was, the fragility fracture, independent of this T-score, even if the T-score is normal, if the person is having a fragility fracture, fracture of the wrist or fracture of the hip or fracture of the spine, he should be termed as osteoporosis. So the number of patients increased. And another thing they did was, earlier there was only normal minus 1 or above, osteopenia minus 1 to minus 2.5, osteoporosis minus 2.5 or below. They added one more terminology, severe osteoporosis. That is, if the patient is having standard deviation more than minus 2.5, and if there is a fracture it should be termed as severe osteoporosis. So these are the two terminologies which have been added in the recent past, in the last 5 years. Quick recapitulation for the people who have just now arrived. Sarda madam and Milind Shah come. So for them, peak bone mass is achieved in the mid-20s up to 35. Post attainment of peak bone mass, it is called as age-related bone mass because bone starts losing from the body. Peak bone mass is a significant predictor of osteoporosis and risk. If the peak bone mass is less, normally the peak bone mass is in children, in ladies it is about 1.25 kgs, and in adults, male, it will be 1.5 kgs. So this you can see, in the female it's about 1250 gram, and in adults it is 1500 gram. The peak will be around 35 years of age, and post-menopausal period, it start declining very fast, and the normal bone architecture of the bone becomes porotic like this in due course of time. If you consider 100 people, 1 in 2 will have osteopenia. Only 1/3 of the people will be having normal, and 1 in 5 will be having osteoporosis. That's our Indian standard. In South India, the people from South India have got the maximum osteoporosis when compared to other part of India. I don't know why, because South India people eat the maximum non-vegetarian food, but this is what the literature says, so I don't know the exact reason. Almost 80 to 90% of South Indians eat non-vegetarian food. Coming to the prevalence, if you take male and female separately, 20% of both of them are having osteoporosis. But if you consider female above 60 years and male above, if you consider age more than 60 years and less than 60 years, then above 60 years, almost 40% will be having osteoporosis. And if you consider only postmenopausal women, again about 1/3 will be having osteoporosis. Coming to the type of osteoporosis, again, there is primary osteoporosis and senile osteoporosis, secondary, miscellaneous, drug-induced, which we are not going to discuss, only we will restrict ourselves to primary and senile osteoporosis. According to WHO, osteoporosis, it went automatically. Osteoporosis second only to cardiovascular disease as a global healthcare problem. Women above the age of 50 years of age and older have similar lifetime risk of dying from hip fracture as they have from a breast cancer. If you see this graph, osteoporotic fractures exceed the number of heart attack and stroke and breast cancer. Just now Bahubali Doshi was discussing about the heart attack. All these three put together also doesn't make osteoporotic fracture. Osteoporotic fractures are much more higher in number when compared to all this. If you see, 1 year after the osteoporotic hip fracture, almost 80% of the patient cannot do one or more activity of daily living. 40% of the patient will not be able to walk independently. There will be permanent disability in 30% of the patient. 20% of the patient will not see the next 1 year totally. So they will die because of this. Even if you consider other fractures also, like putting on the socks, cooking meals, shopping, heavy work, driving vehicle, everywhere they will be impaired after these osteoporotic fractures. This is US data. Unfortunately, we don't have our own data. That's why we had to depend upon what is published. 1.5 million patients will have osteoporotic fractures. 500,000 require hospital admission. 800,000 will require emergency treatment. 2.6 million people will be attending the OPD of the doctor, and 180,000 people will not be able to do their activity on their own, so they have to be admitted in a nursing home. Nursing home in America is an old age, it's not a hospital. What we call as hospital and nursing home. Nursing home is not hospital there, it's a old age home is called as nursing home there. People were getting confused when I went for the first time to America. I said I run a nursing home, means they were getting confused whether I was looking after old people like that. Coming to the osteoporosis in India, there is high incidence of osteoporosis even amongst men. Lower age incidence of osteoporosis as compared to the Western world countries, it's almost 20 years earlier we get osteoporosis in India. The incidence of hip fracture is one woman to one man in India. In most Western countries, while peak incidence of osteoporosis occurs between age 70 to 80 years of age, in India it is almost 10 to 20 years younger. That is, even between 50 and 60 we get the fractures due to osteoporosis. We all know that Government of India and the Health Department gives lot of importance to AIDS. It's seen as a bigger threat because it affects large percent of younger population. But if you look at the older population, in the long term, as osteoporosis affects elderly, which is on the growth path, this will become one of the national health hazard. This will put a larger burden on the healthcare system. The treatment is very, very expensive. Unless we take some quick action now, these consequences will be very, very costly for the country. This is what, when I gave the lecture in 2012, India has not recognized osteoporosis as a health hazard, but you can see that other countries like Singapore, Indonesia, they all have recognized it. So they have allocated funds for treating them. When I gave this lecture again in 2022, it was the same. I am not aware today whether it has changed or not. I don't think it has changed. How India is managing osteoporosis? We have 36 crore people with 36 million osteoporotic patients, 7 million patients with fractures. 47 companies are making anti-osteoporotic drugs. 172 brands of bisphosphonates are available in the market. Only 0.22% patient receive treatment. And even those 0.22% of the patient, they don't take the treatment for the duration we advise, and on average, they take treatment for 14 weeks. So health for us in India is not priority, especially preventive health is not at all we keep money for children's marriage or something happening, but we never allocate fund for health. That is the problem in our country. There are 930 more than 60 years patients admitted in a European hospital, and there are 130 fractures. And those X-rays were shown to radiologists. Only 52% of the cases were reported having X-ray. Means even a radiology missed 1 in 2 osteoporotic fracture in them. 23% were only mentioned in the discharge card about their fracture. Osteoporosis was mentioned only in 17%, and then only 7% of the patient received treatment. As we know that 7% of the patient also receive treatment, may not be complete treatment because they don't take the treatment properly. Coming to the hazards of not treating a osteoporosis, the quality of the life is deteriorated. Fractures, loss of weight, deformity, restricted mobility, pulmonary disorders, mental disturbance, etc. So you'll ask me, why pulmonary disorder in osteoporosis? All these people will have a stooping gradually. The lower parts of the rib will touch the pelvis. The abdominal content will be pushed up. So the capacity of the lung becomes less. Chances of getting infected because of this is very, very high because of the lung is having lesser capacity. All these problems of the lung will start. Because of this, they cannot go out or move out. The social problems, mental disturbances happen, depressions. Even in orthopedics, intraoperative fractures, while we are operating, when we put a nail at the tip of the nail, the fracture happens, refracture happens, implant loosening happens, the cut through, our screw will not have the hold, all the implant come out. The patient requires revision surgery, very, very common in our orthopedic cases. So all these things will happen. As I said earlier, it's a metabolic skeletal disorder characterized by reduced bone strength leading to increased risk of fracture because of the porosity. 1 in 3 women and 1 in 5 men over the age of 50 will have osteoporotic related fracture in their lifetime. It is projected that more than 50% of all osteoporotic hip fractures will occur in Asia by the year 2050. So we will be the people will be producing lot of hip fractures for the world in the next few years. A new terminology has been added, fragility fracture. We also have a fragility fracture network association now in India. It results from this fragility fracture results from low energy trauma, such as fall from standing height. So if the patient is standing and suddenly falls, that is what is called as fragility fracture. If he falls from a height, it is not called as a fragility fracture. Most commonly affects vertebra, especially when the person is traveling in a vehicle. If there is a bump on the road, if jumping happens, the compression of the vertebra happens. Or if they fall down, they fracture the femur, or if they fall on the hand, they fracture the distal and the radius. These three are the commonest site where the fracture happens in these people. It is associated with substantial pain, suffering, and disability, even in death. As per one cohort study, mortality risk with 1 year after the fragility fracture was 12.5% in women and 20% in men. Unfortunately, first fragility fracture is often the first sign of osteoporosis, and we orthopedic surgeons get that for the first time, because this is called as a silent disease. So it doesn't have any signs for the patient to come and show to the doctor. So this fragility fracture is the first sign for the patient, and they come and report to us. Unfortunately, we orthopedic surgeons have got a very bad tubular vision. We only look at the fracture. We don't look at the osteoporosis as a large problem. So we look only at the engine which is giving the trouble, which is the fracture. We don't look at the surrounding. So we only treat fracture. We don't have time to, because these patients are elderly patients. The children, they are least bothered. If they get operated for the fracture, it itself is a great thing. You have to come and see me convincing the patient to get operated. We don't have scheme in my hospital, so nobody comes to me. Even they come, they run away immediately. So it is really the fact, because they are non-productive people in the family, elderly population, so nobody gets the treatment. So we keep this costly treatment aside, and we only treat the fractures. That's the reason why I put this slide, though it is blaming myself. We orthopedic surgeons treat fractures and not the reason behind it, that is osteoporosis. See, this is a case I operated long time back. A officer from railway, the lady, mother had hip fracture. I replaced the hip. Then she came back with a distal femoral fracture. I just nailed it again. That got united. She came again with a wrist fracture. He already had vertebral fractures. This is all in one patient. I am not talking about too many patients. I had started anti-osteoporotic treatment in that patient, but this patient did not take, or probably stopped after 1 or 2 months. So this is happening in a elite society. I am not talking about somebody economically backward. I am talking about mother of a railway officer. So the clinical symptoms is most commonly breaking of the small bones, bone, especially the wrist, due to minor fall. See, this lady came to me long time back with a wrist fracture. I used the Solapur frame. Again, this is a innovation by me. It is a very economical fixator. And she also had a hip fracture. I treated her with a nail, and I started anti-osteoporotic treatment. This is after 14 months, you can see there is a good quality of bone. Patients taking treatment, even if we just prescribe calcium also, taking for a longer duration of time is very, very less. The support from the patient is very, very poor for that matter. The warning signs of osteoporosis can include lower back pain. Many people can come, elderly patients can come with just saying that they have got a backache. It could be due to subtle fracture which cannot be diagnosed on an X-ray. There will be changes in the posture of the person. Gradually they keep on going stooping, and the height of the person will become less and less. They will have shortness of breath, and especially if the disc in the spine are compressed and the vertebra is compressed, they become shorter and shorter, and they will have reduced lung capacity. See, this is vertebral fracture in these patients. This is what happens. Gradually the curve of the bone increases, and then this I will explain coming out. The patient, because of the stooping, round back deformity, one is rib cage touches the upper part of the pelvis, the stomach, abdominal capacity problem will start again. Another thing is, because the abdominal capacity reduced, abdominal content pushes against the lungs, diaphragm, the lung capacity becomes less and less. So they will have problem with the lung. Another thing is, to compensate for the curve in the back, they bend their knee. When you are standing straight, your patella is moving, your muscles are not working, but you have bent, your muscles have to work. So unnecessarily your muscles are working. For walking like this, if I am walking 1 kilometer, I might be spending say 100 rupees. But if they are walking even 10 meters, they are spending 100 rupees for that. Because muscles are continuously working in that. So posture is one which is very, very important that you should correct. Which one way is asking them to touch the head to the back, standing against a wall. This is the best way to teach this exercise to them. This is what happens. Spine becomes gradually curved, lung capacity becomes less and less, abdominal capacity also becomes less and less. Coming to who needs the treatment. Again, American Association of Clinical Endocrinologists, if the T-score is less than 2.5, osteoporosis proven by BMD, then you should start treatment. If there is a fragility fracture history in the family, again, even if the T-score is between -1 to 2.5, -2.5, you should start the treatment. If there is a fracture chance more than 20% or hip fracture chance more than 3%, again you should start treatment for osteoporosis. If you analyze all the people sitting here, 90% of us require the treatment as per these guidelines. What are the medicines which have been approved by FDA? Again, we don't have our own data, that's why we have to resort to American data. Anti-resorptive agents like bisphosphonates, alendronate, ibandronate, residronate, zoledronate, we are all using that. Calcitonin is a very good chemical which is available. Unfortunately, within about 3 to 4 months time, the body produces antibodies. So calcitonin only works for about 3 months in a patient. After 3 months, calcitonin is useless. You cannot give the same calcitonin if the patient comes back to you again. I use this very regularly, especially if the patient is having a vertebral fracture and a severe pain. If you give calcitonin, earlier injections were available, but nowadays only nasal spray is available. If you give calcitonin, pain reduction is very, very beautiful, drastic with that. Then we have anti-rankle antibody, that is denosumab, which we are going to discuss. Then we have hormone-related, right, raloxifene. Then anabolic agents like parathormone, teriparatide. Then dual action romosozumab, that is not available in India at present, so let's keep that aside. How I treat osteoporosis? Today only the patient was admitted, but this I have taken from an earlier presentation. 2017 this patient came to me. This paper is from 2017, not today. Injection tritium PTH, that is parathormone, subcutaneous for 90 days. Injection methylife, that is B12, daily for 5 days. Arekitol, that is vitamin D, Metadec, anabolic steroid, every 15 days. Calcium, then Gemfos, alendronate, weekly, then painkillers. This is what I have prescribed at that time. There are many with hyperhomocysteine and vitamin 12 deficiency. So it's prudent to add folic acid and vitamin B12, not just calcium for them. Homocysteine comes from the breakdown of methionine, one of the essential amino acids used for protein synthesis. Reducing elevated homocysteine level through folic acid supplementation and vitamin B12 supplementation could theoretically ensure proper bone health and prevent osteoporosis. If we all get stomatitis, what we eat? B complex. Why we eat B complex? Vitamin B12 enhances the cell regeneration and proliferation. Quickly the ulcer gets healed. That is the reason why we eat B complex. The same thing this vitamin B12 injection does even in the osteoporotic patients. Coming to all these slides till now are my own original. Now I am going to use the company one. denosumab in postmenopausal osteoporosis. Again, these are some of the slides just to show how denosumab works. We all know the condition osteoclastoma. Denosumab is not a new molecule. I have heard about denosumab sometime in 2000 itself. 25 years back, I have heard about that. I have used in only one patient sometime in 2015. This is osteoclastoma, where osteoclastic activity overrides the osteoblastic activity. This is a tumor. So what we do in these cases are, this is T1 and T2 weighted image which shows the same. We give denosumab 120 milligram day 1, day 8, day 15 and day 28. So osteoclastic activity will be stopped and there will be formation of the wall for the tumor. For us to operate after that, it will be easy. So this is what we are doing. At that time, the cost of denosumab was 45,000 rupees. Now it is available for less than 10,000 rupees. 45,000 for 120 milligram. Now it's 60 milligram is 10,000 rupees. So even now it is about 20,000 rupees. The same case after 4 injections. See, this is preoperative. After giving 4 injections of denosumab, so beautifully the bone has formed. I am talking about a pathological condition where the osteoclastic activity is totally uncontrolled, where new bone is forming. I am not talking about just osteoporosis where the formation will be much more higher. So this how it acts. I will show few more cases. What was done in this patient was curettage and insertion of bone cement and additional support with a plate was given. Another case, osteoclastoma, distal end of the radius. After 4 injections in this patient, new bone has formed. Anyway, we were planning to excise this. So we have inserted a fibula, upper end of the fibula, and we have done the grafting in this patient. Another osteoclastoma, again, you can see this is preoperative. This is after 4 or 5 injections. Then subsequently curettage was done and bone cement was inserted. This is a recently done case done by Dr. Ashish Gulia from Mumbai. He shared this X-ray. All these are not my own cases. As soon as these people asked me to give a lecture, I sent to my onco surgeons, send me cases where I can show the working of denosumab. Then they have sent these X-rays to me. And as you can see, the lower inferior rami is totally eaten up. After injections, this is 5 injections, 0, 8, 15, 4 injections after 7 weeks. So you can see beautifully it is there. And surgery has been done, hemipelvectomy has been done only about 15 days back. Now the plan is to give radiation because they are not sure whether they were able to access completely. They want to give radiation. Because of that, they didn't do the hip replacement at that time. The plan will be once radiation is given, they will be doing a hemi replacement for this patient, a custom made. Whenever the tumor is within the bone, then we can just curate and put a bone cement. But once it extends beyond, then we cannot take the chance. So in this elbow case, the growth had already gone beyond the joint, so it was replaced with a elbow prosthesis. Another case, again you can see, there is a break in the bone. There is a pathological fracture with osteoclastoma, again treated with the same technique of giving denosumab. And since there was a pathological fracture already, it is better to save the life of the patient by replacing the joint. So I thank all my friends for sharing these X-rays with me. Another last case, this is not an osteoclastoma, but it is a bone cyst in a young adult. Again, a bone cyst doesn't require any treatment, slab, it will heal. But the surgeon decided to give denosumab because the bone forms quite quickly and solid union has happened within about 3 months' time. So for that purpose, so it is available now. Now coming back again to the denosumab in postmenopausal osteoporosis. Again going back to the slides given by the company. Rankle is a physiological stimulator of osteoclastic maturation and bone resorption. I'll explain all of them in the next slide. Alteration of Rankle osteoprogerin ratio underline the postmenopausal osteoporosis. Denosumab is fully human monoclonal antibody which is having affinity towards the rankle, and it mimics rankle and it joins with the rank and acts by preventing rankle from interacting with the rank. So this is how it does. We all know that there is a continuous bone remodeling happening in the bone. About 10% of the bone is being replaced every time. Whenever you see the bone, 10% is under that stage. Continuous process where old bone is resorbed by osteoclast and new bone is formed by the osteoblast, that is bone remodeling. Rankle generated by osteoblast. See, when the osteoblast number increases, they only produce some chemicals to kill themselves or to produce osteoclast. So osteoblast only generate this rankle, and once the rankle joins the rank on the osteocytes, that becomes osteoclast. Mature osteoclasts are primarily the mediators of bone resorption through the crypta beta signaling pathway. This is rankle, RANKAL, and this is produced by osteoblast. You can see there is a lot of rankle which are produced by the osteoblast which are lying in the blood. This is rank. This rank is present on the osteoclast precursor. When rankle joins the rank, that becomes osteoclast. So this is the joining of the rankle with the rank that will convert the osteoclast precursor into osteoclast, and they will start eating away the bone or osteoclastic activity. Denosumab is a monoclonal antibody which mimics rankle. So this mimics the osteoprotegerine rankle and also deactivate the rank present in the body. This discovery led to development of denosumab, a drug with a longer half-life and more potent anti-resorptive agent. So we have discovered this denosumab which is mimicking a rankle. So how denosumab acts? We all know this is rankle, and rankle joins with the rank on the osteoclast precursor that will get converted into multinucleated osteoclast that starts multiplying, and that in turn becomes giant osteoclast. And this osteoclast job is to eat the bone, so bone resorption happens. Whereas denosumab mimics rankles, it is similar to rankle, so denosumab joins with the rankle here because of the affinity it has got. So when denosumab joins all the rankle which is available in the body, there is any rankle available to join on the osteoclast to convert the osteoclast precursor into osteoclast. So this will stop conversion of the osteoclast into pure mature osteoclast precursor into osteoclast. So the net result is there will be increase in the bone quantity because resorption becomes less and less. There will be no resorption happening, so bone resorption becomes less. That's how it acts. So it's purely mimicking denosumab mimics rankle which is normally present in the body. Another advantage of denosumab is it not only acts on cortical bone, it also acts on cancellous bone, it also acts on cortical bone. Normally all the medicines which are available at present only act on cancellous bone. So they don't improve the strength of the cortex, whereas denosumab increase the strength of the cortical bone also. Coming to the pharmacokinetics, the absorption Cmax is reached within 10 days after single subcutaneous dose. It is distributed all throughout the body fluid. 5.5 liters is the one which every adult has. It is distributed all throughout in the body fluid. Metabolism, the half-life is 2.4 days, almost a month. So means if I give 60 milligram of denosumab today, Next month, the patient still will have 30 milligram. The next month after, you will have 15 milligram, 7.5 milligram. Every month, it becomes half and half. So that's the reason why give once in 6 months. It's excreted from the reticuloendothelial system, not from the kidney, because all the other things are usually excreted from the kidney, and if the kidney is malfunctioning, you cannot use it. But here, this is from the reticuloendothelial cells. So even if the patient is having any kidney problem, you can give denosumab without any problem. Denosumab 60 milligram administered as a single subcutaneous injection every 6 months is the treatment which is advised. Administer subcutaneous injection in the upper arm, upper thigh or abdomen. What are the indications or the FDA approved indication? First and foremost, postmenopausal osteoporosis in women, men with proven osteoporosis, glucocorticoid induced osteoporosis, androgen deprivation therapy induced osteoporosis, and also aromatase inhibitor therapy. If you use the medicines for breast cancer, you know that they all act by aromatase inhibitor. So if the patient is having osteoporosis due to that, you can use them. Coming to the adverse reaction, though the list shows so many things, in the few cases I have used, I have not seen any of these things. So, but for the mentioning, more than 3% and less than 10% of the patient can have all this problem like nasopharyngitis, bronchitis, headache, cystitis, back pain, musculoskeletal pain, pain in the extremities, arthralgia, hypercholesterolemia, all those things. And even pancreatitis has been reported in few cases. Coming to the FREEDOM trial. FREEDOM refers to fracture reduction evaluation of denosumab osteoporosis every 6 months. It is a 3-year study. They give denosumab twice a year for 3 years, and they measured the outcome. There was a definitive reduction of 60 to 70% in the new vertebral fractures at 3 years. So this was significant reduction when compared to placebo. The number of new vertebral fractures were less. There was a significant increase in the BMD at 3 years, almost 9.2%. So BMD increased by 9% at the end of 3 years. And the same FREEDOM trial was continued up to 10 years now. We have got data for osteoporosis 10 years, and it says that yearly adverse event rates remain stable across the treatment all the years for this, similar to placebo. So there is no adverse reaction with denosumab. Incidence of hypocalcemia, pancreatitis, cellulitis remained very, very low and stable. Very rare case of atypical femoral fracture. Only 2 cases in 10,000 patients were noted, which is very, very common when we are using zoledronic acid or alendronate. 13 cases of osteonecrosis of the jaw, 5.2 per 10,000 was, and that too, all of them mostly resolved. Unlike the osteonecrosis of the with the zoledronic acid, this is a very milder variety. No development of denosumab. This is osteonecrosis of the jaw. This is a picture from zoledronic acid, not from denosumab. Bone biopsies showed normal lamellar bone with maintained mineralization up to 10 years of age. This is about the atypical fractures. Coming to the difference between bisphosphonate and denosumab. We all know that bisphosphonate acts at the pyrophosphate synthetase level, whereas denosumab acts on rankle. The site of action is bone matrix, whereas the site of action is everywhere, all throughout the body. It is dissolved in the 5 liters of the body. Effect on osteoclast. Disables the osteoclast, and the dead osteoclast will remain within the bone. Here, it inhibits the formation of osteoclast only. So there is no dead things which are inside the bone. That is one of the reasons why there is dead osteoclast get accumulated. That's why atypical fracture happens when you are using alendronate. Route of administration, it's oral, daily, weekly or monthly, then intravenous once a year zoledronic acid. Here it is subcutaneous every 6 months. Onset of reversibility. If you are using zoledronic acid or bisphosphonate, the onset is slower, but the effect is continuous, and the effect remains even after some time after you discontinue. But whereas if you are using denosumab, if you stop denosumab, within about 1 year's time, it comes back to square one where you started. So once you start denosumab, you have to continue at least now till 10 years age, 10 years time. By the time 10 years comes, it will be 20 years freedom trial will come. Coming to the clearance, all the bisphosphonates are cleared from the kidney, so you cannot use if there is a kidney problem, whereas it is from the reticuloendothelial cells, this is excreted, so it is independent of kidney, so you can use when the serum creatinine is also very, very high. Effect on BMD, it plateau after several years, it increases but remain plateau after several years. It is robust, quickly increases, it is continuously, but only thing is quickly drops also after you stop the treatment. As said earlier, renal impairment, you can use it denosumab without any problem. Adverse reactions, esophagitis, gastrointestinal irritation, osteonecrosis of the jaw, atypical femoral fractures are very, very common with bisphosphonates, which we are less here. Denosumab versus bisphosphonate. Again, somebody is very happy to give all these acronyms. DECIDE study, determining efficacy comparison of initiating denosumab versus alendronate. Which one to start? Group A, alendronate was given, group B, denosumab was given in them. So there was a race between group A, alendronate versus denosumab. Denosumab won hands down with 3.5% increase in the BMD compared to 2.6% increase with the alendronate. So denosumab scores much over the alendronate. Denosumab versus zoledronic acid with postmenopausal osteoporosis. So here you can see group A was given zoledronic acid intravenous and group B was given denosumab subcutaneously, and the primary endpoint was at the end of 12 months the BMD at lumbosacral vertebra, actually that is L3 vertebra they should have been. So denosumab had a much more higher BMD when compared to zoledronic acid either in the lumbar spine, total hip or femoral neck after 12 months of treatment. So denosumab is associated with greater BMD increase compared to zoledronic acid. Compliance study. This is a very important study which was done where one group was given denosumab, another group was given zoledronic acid, and they interchanged after 1 year. So first 12 months group A was given denosumab and next 12 months group A was given alendronate. So group B was given first 12 months alendronate and afterward they changed. So what happened? Compliance. With denosumab, only about 10% of the patients didn't report for the second injection, whereas in the alendronate group, almost 1/4 of them didn't comply with the treatment. When they interchanged, the denosumab group, which was good earlier, after alendronate was started, 40% did not follow the advice of the doctor, whereas this group, which was bad earlier, they followed the doctor's instruction very well. So that indicates that denosumab is a good molecule which can be used without any problem. Rebound effect. Multiple vertebral fracture happens as soon as you stop denosumab. This is one of the bad things. Following discontinuation, fracture risk increases. Actually, it increases much more than previous. Bone tumor markers, bone mineral density return to pre-treatment level approximately between 18 to 24 months. So to reduce the rebound bone loss after stopping denosumab, one should consider sequential therapy with bisphosphonate. You should consider both of them before you stop it. If you have to treat any patient for more than 5 years for preventing fractures, or if there is a high fracture risk, then if this fracture is there or if there is a high fracture risk, you can continue with denosumab therapy. If there is no fracture risk or there is no vertebral fractures, then you can treat with bisphosphonate. During the course of treatment, if new fracture happen, yes, you can continue, add denosumab. If no new fractures happen during the course of treatment, you can still continue to monitor the patient and continue with the zoledronic acid, but giving an interval. You have to give a gap between continuing after 2 years. In summary, denosumab is the first monoclonal antibody approved by for osteoporosis, acting by inhibiting rankle and suppressing osteoclast activity. It's a potent, long-acting anti-resorptive and superior for fracture prevention. Very simple dosing, just 2 injections per year. Proven long-term efficacy. The FREEDOM study already shows that 60 to 75% reduction in vertebral fractures at 10 years follow-up. Can be used in renal impairment patient also. Better efficacy than bisphosphonate. It has better BMD gains and adherence compared to bisphosphonate. The advantages of denosumab are long-term study is available and they increase the BMD and there is persistent fracture reduction. There is no therapeutic plateau observed like bisphosphonates. No drug holiday is recommended. More efficacious than bisphosphonates in improving and sustaining BMD at the lumbar spine and the hip. Unique bone type uptake equally in cortical and trabecular bone, leading to improved bone quality parameters. Highest BMD outcomes till date with or after teriparatide therapy. There is no safety concern as it is very good drug molecule. Only anti-resorptive drug approved for usage in patients with renal insufficiency where creatinine clearance is between 15 and 30. Offers very long compliance advantage on all these patients. Coming to the regime which is advocated for osteoporosis prevention. In
Excuse
females,
me, sir. Sorry to interrupt, but we are running out of time.
last 1 or 2 slides.
Thank you.
At around menopause, start microestrogen dermal patch. That is, whether it is available or not, I don't know, because few years back I asked, it was not available earlier. Estrogen available now. Defer the treatment. If you use dermal patch, you can postpone the problem because of the estrogen which is not available by another 10 years, the osteoporosis happening. When FRAX score shows fracture risk, start PTH followed by denosumab. If fracture happens, treat with parathyroid hormone and add denosumab. In males, when FRAX score is showing risk, start PTH followed by denosumab. If fracture happens, then add denosumab. Both male and female, if starting point is fragility fracture, then start both of them, PTH and denosumab. If transiting from anti-resorptive to anabolic, then start PTH with denosumab so that the 6 months gap which normally gives problem will not happen with that. To conclude, friends, build the micro architecture first with PTH and then protect it denosumab. For emergency transiting treatment, add the combination therapy. I know it is very exhaustive, but since it is very important because you are the people who are treating postmenopausal osteoporosis, I thought I should give the talk in a comprehensive manner. If there is any question, Ajit, I think you have got a question. As I said earlier, if you want to listen the other side of the story, if there is time, I will share my experience afterwards. There are 20 slides. Yes, Milen.
Last slide was self-explanatory that you say that the denosumab need to be added to the PTH. So, do you think that only PTH will be sufficient to take care of this osteoblastic activity, or we need to add with the denosumab?
See, periterratide, if you are giving for 3 months, 6 months, 12 months, it is of no use. The patient has to take 24 months.
Yeah, we give it for 2 years.
2 years, no patient will take. None of my patients have taken more than 3 months. So that is the basic problem. So if you are using PTH or teriparatide, the patient will not take the medicine because daily injection is something they avoid. And daily injection at what, see, if you are considering 3,000 rupees for teriparatide, 6 months is 18-20,000. Here 6,000 to 8,000 rupees you get denosumab, which is much more cheaper now. Earlier it was very costly. But here now it is only 2 injections, so it's very easy to convince the patient, and once in 6 months they do come for the treatment. But it is better to add teriparatide initially, because their osteoblastic activity is much more stronger. We are doing osteoblastic activity and we are suppressing with the denosumab osteoclastic activity. We are working on both. We are improving the bank balance by pushing in the money. We are withdrawing is becoming less and less. So the balance becomes more and more. So don't depend upon only one.
Thank you, sir, for your elaborative lecture. We now move on to formally inaugurate today's program by lamplighting. I request all the dignitaries, Dr. Shivshankar sir, Dr. Prasanna Kasegaonkar, Dr. Rohini Deshpande madam, Dr. Bahubali sir, to please come forward for President Dr. Sujata to say a few words.
Respected senior members of our society, esteemed speakers and my dear friends, a very good evening one and all. तिळगुळ घ्या, गोड गोड बोला. मकर संक्रांतीच्या आणि रथसप्तमीच्या सगळ्यांना खूप खूप शुभेच्छा. हा पहिला सण आहे या वर्षाचा आणि सगळ्यांना सुख, समृद्धी, शांती, समाधान, पण सगळ्यात महत्त्वाचं म्हणजे छान आरोग्य लाभू दे हीच प्रार्थना करते. उत्तरायण सुरू होत आहे. असं म्हणतात की आता हा सण नॉर्थला चालला आहे आणि इट इज ब्रिंगिंग लॉट ऑफ पॉझिटिव्हिटी अँड इट इज ब्रिंगिंग एनलाइटमेंट. सो टुडे CME वी हॅव अलाइंड टू एनलाइटमेंट अँड दिस इज अबाउट ऑस्टिओपोरोसिस, जे आपण इतकं आता छान सरांनी इम्बाईब केलं आहे ऑन अवर ब्रेन्स की लाईक -2, -1. It is now perfect with us. And second is compression of morbidity. As Ketki has rightly said, the $1,000,000 question still remains whether we want to add years to life or life to years. So, मी थोडंसं लिहून आणलं आहे, ते वाचते मी. The goal is clear. People should have long but more healthier, more independent and more meaningful life. Compression of morbidity is all about reducing the period of illness and disability and improving quality of life rather than just extending the lifespan. To discuss this topic, we have with us stalwarts in the field of cardiology, Dr. Parade sir, he is on the way. Gynecologist Dr. Bahubali Doshi sir, and sir is today our psychiatrist also. He is going to play 2 roles today. Dr. Prasanna Kasegaonkar, renowned neurologist, and Dr. Shivshankar, orthopedician. And the concept was, of course, the brainchild of none other than Dr. Rohini Deshpande madam. A big thank you to all of you for this CME, and I hope that we will have an insightful CME on this subject. Thank you. Thank you very much.
Thank you, Dr. Sujata. Longevity without quality is not success. Dr. Parade sir, an eminent cardiologist, delivering quality healthcare to patients. Shivshankar sir, orthopedic surgeon. He's a warm personality who has enlightened us. And Dr. Prasanna Kasegaonkar, eminent neurologist, recognized for his expertise in neurological and musculoskeletal disorders. To moderate the topic, she very much insisted that we should have a panel on this important topic. Over to you, madam.
Without taking much of time, we would like to start with this panel discussion. In fact, I thought about this topic because I had heard this oration on this topic, and it was really very insightful. And recently, I also had an experience that one of my good friend, her daughter was early hours of morning, she rang me and she said that my daughter is not able to lift her left hand, and also her speech has become blurred. So I was a bit taken aback, and it really shook me because what she was having was a stroke, and her age was 37. So you can imagine that she suffered from the morbidity. She was admitted, and she was given a treatment for stroke. So we are seeing a lot of such patients. Also, Dr. Parade is going to enlighten us because so many young ones are having cardiovascular complications. Hypertension is well known, but even going beyond the hypertriglyceridemia, causing sudden heart attack, chest pain, angina, and also the vascular disease. So it's getting very common. In fact, in our family also, we had such kind of a episode. So I was wondering whether we really have to worry about this morbidity which is coming in the earlier years. And as Ketki said, we have to have a life which is, which is full of vitality. And that is why we are here to discuss this topic. Actually, we owe a lot to this person, James Fry, who is actually a healthy aging pioneer. In fact, he started his career, I'm going to tell about him in a very short. He started his career with a philosophy. So he had a very holistic approach in his life. Later on, he chose a field of rheumatology and immunology. And he was dealing with a lot of patients with rheumatic arthritis and these joint pains and aches. And he realized that these patients, at an early age, they were getting quite morbid because of the disability and pain. So that really shook him, and then he started wondering about the immunological insight into it. He delivered his first keynote address to the Institute of Medicine, National Academy of Sciences in Washington, way back in 1982. While a healthy lifestyle modestly extends longevity, it more effectively staves off the chronic diseases of aging and reducing the number of years of disability, dependency, and pain. So I would like to ask Dr. Parade, what is the impact of changing diseases in the society and how it is affecting our health directly?
Carrying forward from the example which you quoted about your friend's daughter,
Yeah.
just recently, 15 days ago, one of our house officers in Ashwini, a girl, 28-year-old, without any conventional risk factors of diabetes, hypertension, she came to me that while walking she had arm pain. I neglected it because many of these house officers, they have it. They go on seeing different patients and we tend to neglect. But she insisted that she had left arm pain while walking. So I thought, okay, I'll do your stress test. Usually below the age of 30 years, I'm very reluctant to do stress tests, and that too in a girl without risk factors. It was not totally like me, but she insisted, so I did it. It came out to be positive. Still, I ignored it. I told her, okay, I'll do your angiography. But I think we should just start with anxiolytic treatment and then consider. But she insisted, no. While walking out on the treadmill also, I had that left arm pain. So, okay, I did angiography. See, normally you see patients, young patients of heart attack. That's not very uncommon. I have seen young patients of heart attack in 20s, maybe every 3-4 months. In 20s, you have heart attack. So the youngest of my patient was 18-year-old who had heart attack. That is there. That is a thrombotic episode, sudden formation of thrombus or embolus. So it is rare, but what was rare in this girl was she had extensive 3-vessel disease. It was not a single vessel which was thrombotically occluded. She had extensive 3-vessel disease and required 4 stents. So
My goodness.
this is in a 28-year-old girl, my house officer who did not have any conventional risk factors. So that is it. So something is wrong. We should know that something is wrong in our lifestyle. Her lipids were not too much abnormal. She was not diabetic, did not have any strong family history of her mother at the age of 60, 70, she had some minor ischemic episode. So it was not, none of the conventional risk factors fitted into her. But she had a atherosclerotic disease. A thrombotic disease is, you can understand.
Yeah.
Thrombus formation, you can understand. We see marathon runners
Yes.
suddenly having acute coronary syndrome. That is because of dehydration, thrombus.
Yes.
So prothrombotic state, we understand. In pregnancy, it is a perioperative state. You have those prothrombotic. But extensive atherosclerosis in 28 years. In fact, I think everyone in the hospital, they were really taken
Shaken
aback
aback.
and shocked. And I think so we have to look inside our lifestyle. Something is going wrong. Definitely something is going wrong. Not that we have answers today. What the conventional wisdom tells us, yes, healthy food, regular exercise, and avoiding unnecessary stress, keeping your sugars, hypertension, blood pressure, and lipids under control. Those are the conventional things which tell us. But there is something beyond it which we are not able to understand. That's what I feel. In most of our CV events, Prasanna will tell, maybe 80% of the events can be explained by the conventional risk factors. But in 20%, you don't have a clue why.
Yes, I think it is quite something to think about. Do you think the stress of modern society is contributing to this? And what could be the impact of this morbidity on her life?
I think stress is definitely contributing, because now the stress which current generation has is multifold. One is a competitive stress with the peers. See, our own field, they have to give entrance examination every 2-3 years. Right from 10th standard, they are after it. That's a stress, because we see many medical students having coronary events during their residency. So that stress is there. Besides, after that, and that's a continuing lifelong stress, right? Which starts from 10th standard, and till today we are facing that stress. Settling in our practice, doing so much investment, and fighting the competitors. Everything that is a continuous stress. I think that's a stress. Accompanied by the financial stress. But the most, I think, stress which matters, I feel, is the domestic stress. If you are not happy at home, I think that's the worst stress that one can have. That's from the examples which I feel, which I learned from my patients' histories.
Okay.
That's the worst form of stress. You have to, when you go home, I think you have to feel comfortable.
You have to feel at home.
If you are going to get stressed when you are going to reach home, I think that's the worst form of stress.
Right. Prasanna, can you just
I will
enlighten?
just add to what he said. Actually, my residency in JJ was very cool. So, but the practice unfortunately is not. So during that period, we used to get a lot of 8 octogenarian people for regular follow-up. BP hai, chota sa stroke, small aspirin, small dose of ramipril. They are doing well, coming regularly. And one day I just, there in a very early part of my residency, it struck me that, let me ask them, what did they do? 80, 85, very stable, coming for follow-up, they were all okay. So I just started asking them, what were you doing before you retired? Okay, and then there were other patients who were like 65 and then demented, and then they were, very badly morbid. So interestingly, I got those people who were in 8th decade or 9th decade of their life. They were all clerks, postmen, did nothing, they went to job, 10 to 5, came back, had a happy home, couple of children, they are settled, and they are done. But those people who were having very stressful life, they were executives and engineers and the doctors, I found them struggling in the latter part of their life. So this is what you suggested, what Parale sir has said. Stress in day-to-day life actually has got significant role. If you think medically, it raises the cortisol level. So in cortisol, is badly sympathomimetic
condition. So there will be increased heart rate, there will be more blood pressure, it will be much more diabetogenic. So all these things will not only contribute just for cardiovascular things, but they will also add a lot to cerebrovascular events. So as sir said, as you indicated, having a calm life is very important. Especially, I would strongly recommend you to have a strong family work balance. That's a very extremely important thing, not just for your patients, for you personally. So I can give my own example. So I work 7 to 7. 7 p.m. I go home, I am switched off. I am no more Dr. Prasanna Kasegaonkar. I am just Prasanna Kasegaonkar, a husband and a father. So from then on, I have trained my hospital people not to disturb me as much as possible. Unless, some doctor comes or some relative, important relative or a bureaucrat comes or some big time politician comes, I won't go. So unless you try and divide these two parts, totally, things will not be better. And as he said, financial, I'll go quote my own example. So when I started CNS Hospital in 2017, and early on, there is some EMI pressure, till the hospital settles and all. First 6 months, I started having hypertension. I was 43 years of age that time. So BP was good 150, 100 and all, etc. And I just started telling myself, कि कुछ बदलने वाला नहीं, पढ़ लो है ना, घुसो है. And then over next 2-3 months, things started settling. BP today now is 110/70. No drugs required. But then stress did take toll of me. Financial stress did take toll of me for some time, as long as I was under 1.
Yeah, Dr. Doshi, you want to add something?
Since Sujata has given me the role of a psychiatrist, I'll start with 2 stories. One, in 1970, there was a psychiatry class. During MBBS, third MBBS, there used to be lectures. So I remember the lecture hall was at 3rd floor, and one of the senior most psychiatrists in Pune, Dr. Dev, he was going to take a lecture. So we were all sitting in the class and he came. I remember his opening statement. I still remember that. Say, even in 17, the stress has not come today. In last 8-10 years, it is there to him also. So what he said, see, these days are of a very, stressful life. Today, while coming up to the 3rd floor, I was all the time thinking that if I am late by just 1 minute, probably all of you would have gone. And you were all worried and stressed, thinking that I'll come in right time. Another episode I'll tell you. Everyone knows that what stress, toll stress is taking. I used to visit Tuldapur once upon a time. I usually used to say that call me on a working day because keep Sundays free for me. And the gynecologist, she was insisting, sir, this time you come on Sunday. So I said, I'll come at about 9 o'clock. I'll have a set of 1 or 2 sets of tennis and then I'll come. No, sir, you please come. So reluctantly I agreed. I got up at 5 o'clock, started immediately, reached there at 6 o'clock, finished the surgery. By 6:45, everything was over. Usually I used to take tea at their house, but this time they called for the tea in the consulting room only. So just out of curiosity, I asked her, what was it that you wanted to keep this case at 6 o'clock? She said, sir, I have to go to Usmanabad. I said, why? No, I have to attend a meditation class. This all speaks of, we all know it, but we don't practice. Everyone sitting here knows. Everyone confesses that we are under stress, but nobody is practicing. That's the problem.
Yes. Do you think that in that view, that the diseases which are prevalent now, are that spectrum is changing from what we had earlier? Like, let's say that previous era we had lots of tuberculosis, smallpox, but now things are changing, and the pendulum is swinging towards maybe hypertension, heart disease, and all. So,
In my opinion, there are two things. One is maybe really there is a genuine increase in the incidence of all these diseases, and probably it was there, but they remained undetected. Patients passed away, आणि मग ती दोरी तुटली किंवा आमचं कुणीतरी करणी केली, ते लिंबू टाकला, हे पण होतं तसं. त्यामुळं we really, I don't know, honestly. I don't know what is, is there really an increase, or there is an increase in detection rate, or there are new gadgets and new experts who are diagnosing it at an early stage. Honestly, I am not an expert on that.
yes, Dr. Parve.
No, that it is definitely increasing. Yes, we are becoming more aware, we are diagnosing it more. But it is now, that's why these diseases are called as lifestyle diseases. Because the lifestyle has changed. That is something called as epidemiological transition. That means when there is urbanization, more industrialization, certain diseases pop up. This happened in Western countries in 60s, 70s. And 30, 40 years later, it is happening to us. So definitely we'll see our parents were much more fitter than what we are. So it is definitely there, because they are more physically active than what we are. Their food habits were definitely different than our food habits. So the lifestyle has definitely changed. So definitely the disease pattern has changed. The infections were the predominant earlier because of the hygienic conditions, sanitary conditions, and those things. So it is going down. As you see in the Western, it has gone down to from cardiology perspective, rheumatics. When we were studying MBBS, we had many rheumatic fever patients. That is again because of the sanitary conditions, overcrowding, the streptococcal infection was there. But now, see, none of the residents to diagnose the rheumatic fever, they have not seen rheumatic nodules. I have not seen rheumatic nodules for many years, which were a routine when we were doing our MBBS. So the disease pattern
Is changing.
That is one thing. About the stress, which I would like to add, is yes, stress is bad. But there are two types of stress. One is called as eustress, and second is called as distress. Certain amount of stress is definitely essential for our performance. Unless you have some stress, you are not going to perform. Whether you are in the sports arena, the Virat Kohli is not going to score unless when he is chasing. He has that certain amount of stress that stimulates him. So that's a eustress. The stress, what stress is, that increases your catecholamines. It increases your catecholamines, so it increases your heart rate, blood pressure, and that it brings to the optimum level for your heart to function and your muscles to function. And you are more alert. When the catecholamines are built up, you are more alert. So that is eustress. But if these catecholamines persist for a long time, then that becomes a distress. So if the catecholamines go up and come down, as soon as the triggering factor is gone, that's the eustress. But certain stress, the chronic stress, the financial stress, the domestic stress, the stress of practice, that becomes a chronic stress. So if these catecholamines persist for a long time, they lead to the muscle fatigue, they lead to mental fatigue, and then we have these problems.
Okay. Do you see anything, anything changing in field of neurology or neurological?
Absolutely. I would just to add one point to what I've been discussing. It's the increasing age, average age, which has changed the spectrum. So previously, the average life expectancy was around 60, 64, maximum 69 and all. If women would live till 70 and men would perish by around 60, 65. But now the life expectancy has gone well beyond 7th decade. People are surviving till 80, and that's the reason why we are seeing those diseases which are related to old age. Say for example, Alzheimer dementia. So previously there wasn't much of a talk of Alzheimer dementia and then brain health and all. So strokes you will see in old age, that's no big deal. But then things like Alzheimer, Parkinson's,
Yeah.
then normal pressure hydrocephalus, these are very classically old disease, old age related disease. They are much more seen. And as sir was talking, people dying of, of unknown, dying of old age. So we call them as now encephalopathy. Okay, so what happens, एखादा म्हातारा किंवा म्हातारी 85-90 yearsची झाली की थोडंसं आजारी पडतात and then they stop eating and then they slowly perish. Many times we don't let them die now because we will find some UTI, encephalopathy, little, sepsis and all. You try and pick those things up, small things, pick them up and then treat them. And nowadays with molecular things coming up, things like paraneoplastic disorders are very much there in neurology. So you are having paraneoplastic cerebellar degeneration, paraneoplastic autoimmune encephalopathies which present as just seizures and rapidly deteriorating neurology and people dying. You diagnose them, put them on IVIG, then put them on immunosuppressant, then they survive for another decade. So a lot had changed. With the changing age pattern, you are seeing more disease related to old age, and secondly with better diagnostic facilities and more insistence on trying to find a diagnosis, we are able to not only delay the death, we are able to also delay the morbidity which is an important topic of discussion for today.
Yes, actually James Fry was, he put forward this theory, and his main hypothesis was later you get morbidity in your life, and the time which goes from that morbidity to the terminal illness and your death has to be as short as possible. But if you get a morbidity in earlier age, maybe let's say in 40s, 50s, and you live up to the age of 80, which is a life expectancy, so you are having a period which is much longer full of morbidity. So you are incapacitated for your routine normal activity, or you have got some disability, impairment, and this is not the life that you would like to have. So as far as possible, you should have some behavioral changes or maybe interventions which can actually, take this morbidity further in your life. So this is what we are trying to aim. So Dr. Shivshankar has aptly put forward the bone health. So what are the interventions you would recommend? Of course, you have put forward all these pharmacological things, but let's go from your side first.
Basically, I will tell one about the earlier discussion. Earlier, we were not having so many doctors, so many investigate modality, so people were dying. So nowadays, we recognize everything early. For example, even 20 years back, getting a arterial blood gas analysis in Solapur was difficult. Even the electrolytes to test, it was very difficult 20-30 years back. So people used to die because of that. Nowadays, we all treat them and make them live for another extra few years. That's one of the reasons. Even CT scan or MRI was not there in the 90s. The first MRI came in Sholapur in 1994. So before that, we were treating patients, but it was all open and close, like the surgeons used to do. So if there is nothing you can diagnose clinically, you open the abdomen and see it. So morbidity was much more. Now with the investigation modality increased so much in the last many years, we don't require anything. The MRI gives a cut section of the body as if I have chopped the body every millimeter and see it. So that investigation we get. That's one of the reasons why the longevity has increased, and because of the longevity, the problems we are now facing is of the old age and other diseases we are seeing. About the bone health and other things, basically you have to keep your muscles, bones strong by doing exercise.
Yeah.
There is nothing shortcut for
Yes.
that. You have to keep your body weight under your control so that your joints are not overloaded. You have to move all the joints. If you have got knee pain, it doesn't mean that you shouldn't move the knee. the knee has got a cartilage which is like a sponge. Sponge will absorb water only when it is compressed. So if you are not moving the joint totally, the part of the joint will not get nutrition. They are the one which start degeneration first. So many doctors, amongst us only we tell, if you got osteoarthritis, don't sit down. Don't do this, don't do that. No, it's not correct. You have to keep moving your joint, then only you will be retaining the joint movement. So how you do it is different. Instead of weight-bearing activity, you do it non-weight bearing activity. Like you can go for swimming, or you do cycling, or you sleep on the bed and keep moving your joint, all those things. So strengthen your muscles, strengthen your back, strengthen your core. There is no alternate for that. And again, as I was telling earlier, bone health requires you have to do outdoor activity. There is nothing which can improve your peak bone mass apart from having a regular exercise in the childhood. Unfortunately, everybody is now busy with a mobile. They sit on the computer, so they don't go out. There is no sunlight available for them. All these things, that is one of the reasons why we are facing the problem of obesity in childhood, hypertension in childhood, all the problems. In the next 20, 30 years, the problem is going to get complicated. What we are telling, postmenopausal osteoporosis or senile osteoporosis after the age of 60, probably we will see at the age of 40. This because their peak bone mass has never improved to that extent. So there is no shortcut for anything. You have to do exercise at least 5 times a week, and 2 days of cardio and 3 days of muscle training, or at least walking is one of the simplest exercise that will improve your eyesight. And you should also prevent your fall. Means one of the elderly people, they'll postpone getting cataract operated. They fall. Many of them, they fall in eye hospital and they come to us because they are unable to see that. This is an unknown area, because in their house they know where is the threshold, where is the, they have to have the steps and other thing. But when they come out of their house, they are at a loss. So they fall and they sustain the fractures. So improving the eyesight, looking forward and looking around is very, very important. When you are walking, don't look down. So balancing is very, very important. You should be able to balance yourself. If somebody pushes you from behind immediately, you should not be, that's what is required. That can be done only by exercise.
Dr. Parade, what are the interventions regarding the cardiac health? Interventions to prevent the morbidity.
You mean control of blood pressure?
No, in general.
So now the intervention will fall in both. One
Because you were telling something like a polypill previously, you were advising.
Polypill, okay. The polypill concept was put forth in 2003 by Professor, I think, Law and Ward from London. The concept, they were the epidemiologists. The concept was that if you, that time it was proven that that time it was believed that aspirin reduces cardiovascular events, antihypertensives reduces the cardiovascular events, so also statins reduce the cardiovascular events. So individually they all reduce the events. So they statistically, doing some statistical jugglery, they showed that if all of these were combined together, you can bring down the coronary events or cerebrovascular events by 80%. Normally, if you see individually these drugs, they reduce by 10%, 20%, 30%. But they said that if you give this drug in combination, that is just using the statistical methods. So this was the concept they put forth called as a polypill, wherein 3 antihypertensive agents, 1 diuretic, 1 beta blocker, and 1 ACE inhibitor. And these 3 antihypertensive agents were used in low dose so that there should not be hypertension, half the recommended dose. But if these 3 to be given together, then it can bring down blood pressure. That was the concept. Plus aspirin and plus statin. And that time they also added folic acid because a concept was coming that increased
Homocysteine levels.
is essential, is one of the causative factors for the thrombotic events. But subsequently that theory went off that the homocysteine, it doesn't play much role. In fact, one trial showed that supplementation increased the coronary events by bringing down the homocysteine. So that went off. Then that was the theoretical part. Then some studies were single center studies were done, some multi studies were done, and what was put forth was not quite translated into practice. That means they said more than 80%. In practice, some studies hardly there was 20%, 30% improvement. That is one thing. The second thing, side effect of one of the drugs in that combination made people stop all drugs. Like ACE inhibitor, there was cough. Calcium channel blocker cause edema. So one side effect of that drug, which patient doesn't know, then it made stop all the other beneficial drugs. So the adherence was good, compliance was good, but the end result, there was some in fact, there are two large trials going on which the patients have been enrolled, I think in 21 or 22, 5 years. So 27, 28 we might have result for primary prevention and secondary prevention. But so far the studies have not definitely said that giving that polypill clinically is useful. It is not, has not translated into practice. The other problem of that polypill is you cannot dose adjust. A certain patient might be hypertensive. For him, he might require more dose. So you cannot, a single pill you cannot dose adjust. So those were some practical considerations. Of course, what was preached that time or what that world suggested that time, this is mainly for the resource constrained countries where you have, the people can't afford all fancy investigations. So a single pill, irrespective of what your blood pressure is, irrespective of your cholesterol is, whatever your status, take this pill daily who is above the age of 55 years. It was the above age of 55 years. So you take this irrespective of what, and it is going to bring down the events. There was some 20-25% reduction in the events in some of the small trials. But the multicentric trial, this is yet to be proven. So I don't think we are still there that we should prescribe a polypill. It looks an attractive concept. It is cheaper, practicable, but still we are not there.
Dr. Prasanna, what kind of intervention you think
Yeah,
for dementia, Alzheimer?
Yeah, absolutely, absolutely. So apart from the standard things like keeping blood pressure under control, keeping lipids, weight, sugars, etc., for brain health, there are a lot of things which are very important. First of all, it is very important that you never retire. Okay, you should never retire completely. That's what I would strongly recommend. I have seen enough people who were absolutely top-notch people. One day they just retired, and within 2 years they developed dementia. You know, my heart bled when a math teacher who was taking excellent tuitions till the age of 70, 71 years, and he was pretty healthy. He left, and 2 years down the line, he could not do 20 minus 3 minus 3 minus 3. So one thing is that for the brain, the exercise is data. Okay? So you should be having knowledge. Read, watch, but then always be behind knowledge. Let this be in your field. Let this be a general knowledge. Let this be politics. Let this be sports knowledge. You must have knowledge, number one. Secondly, for brain health, it is very important that you have good eyes and ears. People are very keen about keeping their eyesight okay, but deafness in general is overlooked by most of the people, including our own parents. Our parents are a little deaf, and we are okay with that. ते म्हातारे आहेत त्यांना विशेष ऐकू येत नाही. But then you are not charging the brain. It's a mobile. Right? So where is the data coming from? It's from the eyes and it's from the ears. So you have to ensure that people are having good eyes and ears till as late as possible, till the time when everything else is thing. There is a significant role of keeping the parents, especially everybody of us is having 1 or 2 elderly at her home. Try and keep them in the center. What happens, as we take the center part of the stage, center part of the family, our parents slowly are reduced to their bedrooms. We are working all the day, we eat, we go to their room and we ask, "Jevla ka?" And then they say, "Jevlo, kai jevla?" And then they tell, and then we are okay, good night, and we are back. Okay? Nobody goes to them and tells them how was their day, what happened in their day. None of the grandchildren, and we set the same example to our children, and the children treat the grandparents the same way. And this is one of the major reasons why the dementia will come up. So the social separation is one of the major risk factors for dementia. So it's important that we keep. So for prevention of dementia, Sudoku has got class A evidence. Okay, it's a simple thing which we have apps and there is everything. It's there on everyday's newspaper. So those people who are solving Sudoku on a regular basis are less likely to have dementia. So what does this tell? So Sudoku is a brain stimulation. So it's important that you take care of your brain. The best example I can remember is Dr. Varerkar sir. He was in his 80s, 82, 83. I saw him bright like a 26-year-old pediatrician. Because this man was practicing as late as he could. And I'm amazed, how nature is different. He had triple vessel disease, he had very bad heart. But his carotids were beautiful. Now, you think why his carotids remained, because it's an atherosclerotic process, The cholesterol doesn't know where to go and where to block and where to keep it open. So possibly his carotids remained open because he was using his brain a lot.
Okay.
So I mean, these are small take-home messages that I want you to take home. Not just for your parents, but it's for yourself also, because everybody will turn eventually 60, 65. And I would really want you to, keep yourself busy within the limits of your physical ability. Of course, I don't want, nobody of the age of 70 years should be working 18 hours for sure. But then keep yourself busy. One example is sitting in the second row also.
Yes, I agree, Dr. Prasanna. I would also like to appreciate. Yeah. I must appreciate also Dr. Bahubali Doshi, who has been really being a role model for being very fit, and he always take interest in all the activities which are run by SOGS, and even otherwise also he is, keeping himself busy in lots of other activities like singing, maybe it's acting or going for some travelogue. So what do you think, how you are leading your life?
Prevention is better than cure. So now I go in the role of a gynecologist. And my suggestion to the obstetricians and gynecologists, say, when Prasanna told me, I really envied him that after 7 o'clock, he is no more Dr. Prasanna, he is Prasanna. We obstetricians, we cannot do this. Then what can we do? See, first of all, which I am not preaching something which I have not practiced. I have practiced in group. I requested one of my colleagues to join me in the sense freelancing. But whenever I had a surgery, I used to call her. After that, I joined Dr. Dabade and Kumthekar, and then again we have a group practice. In the meantime, I invited one more young gynecologist to join me. She worked with me for 14 years. After that, I stopped obstetrics. But I request you that you please do a group practice.
Yes.
And then about retirement, yes. निवृत्ती ही वृत्तीमध्ये आहे, फिजिकल नाही आहे ती, शारीरिक नाही आहे निवृत्ती. तुम्ही वृत्तीने निवृत्त राहा म्हणजे मग त्या रंगुनी रंगात साऱ्या रंग माझा वेगळा, गुंतुनी गुंतात साऱ्या पाया माझा मोकळा. तर ही आयुष्याची फिलॉसॉफी पाहिजे. Then I'll give you two examples where you can prevent a disease and you should not overdo things. One example is Angelina Jolie. She used that study of genetics and got her bilateral mastectomy and she became disease free. And another, that Kata Laga girl, Shefali, she was, doing surgery, she was taking Botox and whatever, all sorts of things, and she died at the age of 40 or even earlier, I don't know, 42. So, see, life is an accident, death is natural, everyone is going to reach that. What is more important is how we lead it, and again, greed is relative. Everyone knows, but still, nobody wants to say, you go ahead, I am here. You just be with them, or rather, just one stage or one step behind the younger people. When I started practice, one of a very senior pathologist came to meet me with a cheat pad. If you have any cases, refer me for investigation. That time I felt, what is this? But today I realize that that is what kept him fit. And all the activities, sports, exercise, going out. Even now, Shiva has told us that 30 ml into how many? So that is also okay. Not necessarily that you should have it. What I want to say, let Devanand be your role model. Stay with younger people. Always work with younger people. If you join the old people, गुडघे दुखतात, कंबर दुखते, पचत नाही, होत नाही, झोप येत नाही. So, if you want to be normal, you be with young people, let there be a role model like Devanand, and not somebody who says, माझं कार्य संपलंय, आता मी चाललो. यांच्या बरोबर चुकून सुद्धा जाऊ नका.
Thank you very much, Dr. Doshi. So we do see that there is a paradigm shift in all the diseases that we are experiencing now, and as everybody rightly said, it's a lifestyle change that we have to look forward to.
Not lifestyle change, madam. It's company people who do that. See, when I was a MBBS student, 180 milligram of blood sugar was, we were calling as diabetes. Then they made it 160. Then they made it 140 fasting. Now they have made it 126. Yeah. So, all the things, what Dr. Parle was telling, single medicine for cardiac, anything can prevent. These are all marketed by these people. Even in orthopedic, we had a Pfizer people telling that steroid has to be given for cord injury, spinal cord injury. And afterward, they had to give a lot of money to the government because of it was a misquotation of the study. At 3 months' time, there is a marginally better improvement in the cases where steroid was given against steroid was not given. At 6 months, both of them were same. So, there is a lot of things which needs to be, even BMI, earlier 28 was supposed to be taken as obesity. Now they have brought it down to 25. So
Yes.
we are creating patients.
Yes.
Even like osteoporosis, I was telling, osteoporosis was a general, it's a common thing happening in everybody. It's not a disease.
It's a progression of a
It's
natural.
a process which is a natural process. Now they have made it into disease. Machines will determine. Earlier we doctors were seeing the patient and we decide what to be done. But nowadays patient comes with a report. Sir, I have got osteoporosis. My T score is minus 2.5. So the machines decide who to be treated and who not to be treated.
So our first choice would be non-pharmacological.
Yeah.
Oh,
So every disease, if you take any disease, blood pressure. Earlier, blood pressure we were telling that 8 plus 100 systolic is normal. Say I am 60 now. So 160 is normal. That was what we were telling. And diastolic, anything above 100 was abnormal. So they now brought it to 80. Recently they have brought it to 80. Recently last month there was a paper article saying that the cardiac problem is same as above 90 millimeters of mercury or between 80 and 90 millimeters mercury. So our aim is to control the blood pressure to 130 by 80. So if 130 is considered as a normal systolic blood pressure, everybody in this hall is a hypertensive.
yes. So we have to take it more forward. So this is a very compression of morbidity is definitely a positive concept. It's groundbreaking, and we should have a vision to really, choose the interventions. So ideally, the long life with a relatively short period of terminal decline, that is what we will be looking forward to. So this kind of a hypothesis has generated lot of research. So many papers have been published considering this hypothesis, and it has actually culminated into strategizing public health policies. So there are so many modifiable variables like obesity, diabetes, hypertension, heart disease, smoking, alcohol, lack of exercise, and some mental endurance issues as well. So we have to look into this. So I feel that we have presented this and everybody has contributed this to from their faculty, and this is dedicated to all those who have managed to grow very healthy and leading a positive lifestyle as well as both physical and mental. So I wish you best of health and happy life and happy Makar Sankrant. Thank you.
Thank you, Dr. Rohide Madam, for such a wonderful panel, and also all the panelists to have come here from their busy schedule. I would now request Dr. Sujata to please felicitate our panelists.
Thank you all the panelists, Dr. Shivshankar, Dr. Parale, Dr. Prasanna, and Dr. Bahubali Doshi for taking your valuable time and joining us. Thank you. And thank you all the audience for being here.
Lata. And also her guide and mentor, Dr. Tirankar Madam. So we would like to felicitate Dr. Shivani as well as Dr. Tirankar Madam on behalf of SOGS. Please come forward.
For 13th of February for चितळे oration, and can everybody come for a group photo? पटकन येऊ शकत असाल तर या, नाही तर मग जेवायला चला.